So when you do how many of you really do the gonioscopy in your daily practice? Okay, which lens all of you have? You have a single mirror, 2 mirror, 3 mirror, 4 mirror, 6 mirror, single mirror, 2 mirror, 3, 4. Okay, somebody has 6 mirror. Okay, fine. So gonioscopy is very interesting. Many of us, we don't practice the gonioscopy. The simple reason is that we have to use the coupling solution, and then there is always a leaking on the face, and it takes its own sweet time for us to do the gonioscopy. So that is one of the main reasons why many of us try to avoid the gonioscopy. But let's see some clinical scenarios. That's how we used to read in the applied anatomy, the clinical scenarios. So before we just go into the depth of it, all of us do have this, how do we really see the corneal wedge? So that's why I wanted these lights to be off, but unfortunately the light is on. So just have to go with the full width of the beam, reduce the height and keep the width as full. Now you can see the angle very clearly. There's only a Schwalbe's line possibly is seen, and then adjust it. And once you have done this, reduce the height as minimum as possible, and then keep watching here. I'm not sure whether you'll be able to see in this. See here, slowly keep watching it. It's not very easy to really show you the corneal wedge, but unless the light is not there, only when the light is not there you can possibly see this. So once, I'm not sure whether are you able to see? Okay. So see, once both the lights comes in place, and then this is the area where you need to look at it. I can see from here actually. Now actually it is seen beautifully. This is the corneal wedge. And then, I'm sorry about that. If you really want to see the corneal wedge, I can show in my laptop. So each structure is very important. Like we'll go one by one. When you are looking at the Schwalbe's line, this is where the pigmentation happens. We usually have the confusion in the Schwalbe's line pigmentation versus the trabecular meshwork, and which is the pseudo-exfoliation and which is the pigmentary glaucoma is always the confusion. So this is actually the pigmentation of the Schwalbe's line. You can see beautifully here. This pigmentation is always very irregular. Patchy pigmentation is the Schwalbe's line. You put the slit beam very thin, make sure that you identify the Schwalbe's line, and then once the pigmentation is there, this is the pseudo-exfoliation. And then you have the eye syndrome again, that you can see that. And when you're looking at the homogeneous pigmentation, the trabecular meshwork, you see this here. This is very dense pigmentation, and this you will be seeing throughout 360 degrees. That is the pigmentary glaucoma. There's a huge difference between these two. And you see here, this is irregular and very patchy. This is very irregular, though it is dense here, but this is very irregular and patchy. This is the pseudo-exfoliation. You can see here, this is the PXF, very irregular, patchy. And you see here, this is a dense, uniform pigmentation, and it is much more broadband. So this is one patient, which is very interesting patient. Patient came on the first visit. When we saw the patient, it is about 40-45 IOP. I couldn't do the proper gonioscopy because of the corneal edema. When the patient came back again, she is a woman. And when we did the gonioscopy, this is the finding. Any of you want to prompt your possible diagnosis in this patient? Any clues? What you see here is a blood clot, and of course there is an NVA in the angle. You can see the NVA, and there is a very micro hyphema. When you put your slit lamp and see, this was not seen. Only when we put the gonioscopy we could see this. Any idea what could be the possible diagnosis in this patient? Can you think? Okay, this patient turned out to be a carcinoma breast. So the moment you see the NVA, any unexplained NVA with a small amount of this kind of a bleed, you have to always rule out any malignancies. because I have seen many of these patients. I have sent the patient to go for the gynecologist opinion. The moment she went there, she got the diagnosis as a carcinoma breast, and of course it was in the secondary stage. So it is very, you can pick up so many things like this, like viral etiologies, or so many things we can look at. So see this, there's a very tiny microhyphema with a bleed there. And when you are doing the trabeculectomy, we need to make sure that whether the ostium is open or not. If you want to really see that where exactly or what is the actual cause for the high IOP, is the scarring of the bleb or is it the ostium is closed? So you just go see the ostium. You can see a small pigmentation in the ostium, but ostium is still open, patent ostium. So you can always go ahead with that. This is not the reason for the blockage of this is basically the scar formation. When you're looking at this is the angle recession. Pankaj was showing beautifully about all the structures. So you just see here how widened is the ciliary body band. So wide ciliary body band is typical finding of the angle recession. Once you see this angle recession, then obviously you can say if the angle recession is larger the area, then the possibility of patient developing the secondary glaucoma is high. If that is very small, then possibly you can still watch. But when you have a traumatic angle recession like this, you still have to watch the patient for next 10 years or so. Patient can develop angle recession glaucoma. It takes really a lot of time for the patient to develop the angle recession glaucoma. Why I am showing you this little longer video is you should never forget this in your mind, how the wide ciliary body band can be visualized. And again, like what Prasanna was showing you is about the iris processes, filiform process, small iris processes. You can still see the background, you can still see the structures very clearly. And of course, this is the same. And this is the patient with the Aniridia. Sometimes it is really difficult for you to see whether the patient has a stump or not. If you can just put in your gonioscopy, you can still visualize the iris stump. And whenever you are doing your trabeculectomy, especially in a patients where you are given neovascular glaucoma, you have treated with Avastin injection and the neovascularization is completely gone off. But when you want to do a trabeculectomy, you still have to do the gonioscopy to make sure whether there is any angle vessels are there or not. Wherever there is no angle vessel, then you go pick up that area to do the trabeculectomy. If you go and do the trabeculectomy in the area where the NVA is still present, you can expect a profuse bleed from there. So that is one of the areas where I really appreciated the usefulness of a gonioscopy. So these are the secondary glaucomas. You have to put in your gonio lens and see what is the actual reason. Once you see the hyphema like this, we may not know what exactly is it from the angle neovascularization of the angle, or is it from the stump which is kind of a bleeding from somewhere, or what is the actual cause we need to see. So this kind of angle bleeds we need to really pick up. And this is the foreign body, and melanomas, we can easily pick up melanomas. Foreign bodies we can pick up. Cyclodialysis cleft is not that easy for you to pick up because the eye is little softer. When you put the gonio lens itself, the eye will collapse. So we may not be really able to visualize that. And iodine crisis. So again, we can keep showing lot of pictures about the gonioscopy. In that, gonioscopy is extremely useful. You can pick up all malignancies, traumas, every possible for your surgical, when you want to go for the angle surgeries, you have to do the gonioscopy. So just make sure that you all practice gonio. The purpose of this particular course is, please do the gonioscopy. Though we have so many courses, but still we are unable to make sure that everybody does the gonioscopy. But once you start understanding that how many things we can pick up, then probably you will have some more interest to do the gonioscopy in your regular practice. Thank you so much.